And microdendal can be given for 4 to 6 weeks post event. And another very important drug that we give is your ivabradine. Ivabradine. I don't know whether you have heard it or not. Ivabradine is it reduces the heart rate, but it's not a beta blocker. It reduces the heart rate, but it's not a beta blocker. It doesn't reduce the contractility of the myocardium. It acts on the ion channels in your pacemaker, pacemaker. SA node, sinoatrial node. Sinoatrial node is a very small, just like your chanaka dal, small one. There you have sodium channel. We call them as a funny channel. I don't know how many people have heard funny channel, FUNNY. The funny channels are sodium channels. They are present in the small tissue of sinoatrial node, SA node, or is a pacemaker. So there, the ivabradine acts on that, and it blocks the channels and it reduces the heart rate, but it doesn't have any action on the pumping capacity of the heart. So these are the drugs that we give in, and if the patient becomes all right when you're discharging, patient has to go on antiplatelet and anti-anginal, and sometimes these ivabradine also we give for some time. These are the important drugs. And when we are talking about anti-anginals, I spoke about nitrate, beta blockers, calcium channel blockers, potassium channel blockers, but nothing is superior to others. So they're all equally good. Sometimes you combine 2 or 3 also for the additional synergistic action. Then, of course, the basic pathology, basic pathogenesis is the fat deposition, cholesterol deposition. You have to keep all these patients on anti-platelet, anti-cholesterol measures. Statins is a wonderful drug of this millennium. Statins are wonderful drugs of this millennium. They are anti-cholesterol medication. So these patients should be on anti-cholesterol medication like statin for lifelong, for the secondary prevention of this myocardial infarction. So, and sometimes we get typical chest pain patients, typically a female chest pain patient. When you take an ECG, ST elevation is there. When you do coronary angiogram, all coronaries are normal. I leave it to you. Guess what this could be. A female patient coming with typical chest pain setting. When you take an ECG, there is an ST elevation. When you do an angiogram, coronaries are normal. What is this called, Lisa?
Vasospastic.
Huh?
Vasospastic.
Vasospastic is a good answer. That is called prinzmetal angina. Vasospastic angina or prinzmetal angina, especially females. We are worried. We think it is MI. We think it is MI. You do a TROP-T, be negative, but ECG will show, a patient will come with typical chest pain. ECG will show elevated ST segment, and then TROP-T will be negative, angiogram. No. So unless you do this, you will not know whether we are dealing with this prinzmetal. This is called prinzmetal angina or vasospasm or vasospastic angina. So I think there are MI mimics also. There are MI mimics. All this is a take home for you. All ECG MIs are not real MIs. All normal ECGs are not real normals. You should remember this. ECG is the photograph of the heart. ECG is a photograph of the heart. It depends on what time of the pathogens you are taking ECG. So all ECG MIs are not real MIs. All normal ECGs are not really normal ECGs. So you should remember these 2 points. Therefore, when you are just seeing one ECG and say it is normal, no, you have to study it. ECG is a book, very big book. I wanted to do one full day ECG, actually one full day ECG workshop with all beautiful examples, because there is some non-heart disease, non-cardiac disease also can have ECG like MI, like your acute gastritis, pancreatitis, cholecystitis, and sometimes pneumonia, sometimes pericarditis. They can cause acute elevation patient may come with chest pain. So these are all MI mimic there. Non-cardiac causes of ECG abnormal. So we also should, that's a medicine is a very interesting, beautiful, and at the same time complex and difficult subject. But once you go into the depth, you will enjoy like anything. And you have to do night duties. Night duties are opportunities for you. Nowadays, the youngsters, they're afraid, oh, I don't want to night. No. The more number of duties you do, the more expensive. This is the time. You have to have more knowledge, more experience of your patient. Patients are our teachers. The junior docs nowadays, they're searching for where is more salary, where is no night duty, they're choosing that pathetic. It is not correct. The more number of night duties you do, more you learn. I told you, I've done 10 years of physical night duty. Physical, not virtual. So I can treat any patient coming to me, thankfully. Though I do mistakes. So, like somebody has acute stroke, ST elevation may be there. Somebody has subarachnoid hemorrhage, there may be ST elevation. So if you think this ST elevation is a myocardial infarction, if you give heparin, what will happen? Patient already has subarachnoid hemorrhage, and the ST elevation is because of subarachnoid hemorrhage. So all ST elevations are not necessarily due to acute MI. Please remember this. You have to read, you have to interpret ECG very carefully. If you are not understanding, take the second opinion from your senior or a cardiologist. Almost every day I get ECGs on my students, my PAs, my DNP, my MD students. Send ECG, sir, what is this? See, nobody knows 100. What I know is only 1% of ECG. Nobody can read, say that I'm 100% I know ECG. It's a big book. Every ECG has different meanings, different explanations. As I told you, cholecystitis also can present acute ST, pancreatitis can present acute ST. So that is the beauty of our profession. You should enjoy it. Uske maze lena. I think we'll stop here. 8 o'clock. I'll answer a couple of questions for you. And then close.
So can the internal medicine doctor do primary?
No, you're not allowed to do. Internal medicine. You're asking anything?
No, I'm asking.
So, Sadat is asking, can an internal medicine doctor? No, they're not allowed because you don't have practice. So if you want to do angiogram, angioplasty, you should have practice for at least 3 years as a super specialist, as a DM cardiology candidate. They don't allow physicians to do it, and you're not supposed to do it. You cannot do it unless you do on many. And every patient is a challenging because the coronary anatomy is not same for everyone. One vessel may be long, one vessel may be left, one may be going right. It's a 100% variable from person to person varies. So you should have experience where to put the guide wire, how to negotiate, how not to rupture. We have seen some patients dying on the table, cath lab table, because the guide wire that we are thinking ruptured one of the coronary arteries.